All right, folks, we're here now at chapter 46. This is the last podcast series. This has 108 slides in this particular slide deck, and this is a big section. The best way to think of this section is kind of the integumentary system or the dermatologic system, and we're going to break it down into three sections, each section covering about 30 slides. And in order to know where we're going, we have to know where we've been, and we have to be able to know our roadmap. And so let's start with an overview of the skin. The skin's the largest organ, covers the entire body, and it accounts for approximately 20% of the body weight. We have accessory structures of the integumentary system, including hair, nails, and glands. And the primary function is to protect the body from microorganisms and infections, ultraviolet radiation, loss of body fluids, and the stress of mechanical forces. Other forces, or other functions rather, it regulates body temperature. So think of the young and the old. Also think of burn patients and those who've got issues with skin and skin disorders and their ability to regulate that body temperature. It's also involved in the production of vitamin D, is involved in immune surveillance, and it provides important protective functions and pleasurable sensations from touch and pleasure receptors. Layers of the skin include the epidermis at the top layer, the dermis being the middle layer, and then subcutaneous or hypodermis being that bottom layer. In a couple of slides, they'll have a pictorial visualization of what these areas represent. The epidermis includes superficial outer layer, and it has the stratum, basal, germinatum, spinosum, lucidium, and corneum levels. And so we have the stratum, corneum, and then we had the granulosum, and then the spinosum here, and then think of basement layer, so the stratum basal area, and you'll have the squamous cells here, as well as the cuboidal cells. You also have some keratinites, which looks like to be right in that cuboidal cell. And then you have the melanocyte, which has the melon. And then we have Langerhans cells, and then Reet-Ridge, and it's that area right here. Within the epidermis, the keratinocytes contain keratin. The melanocytes are the melatonin, and one disorder is vitiligo, which is an autoimmune-related loss of the melanocytes, and then that results in depigmentation of patches of skin. The Langerhans cells present process antigen to T cells, and then the Merkel cells, which function as slowly adapting mechanical receptors. Now, when we get to the deeper level, we have the dermis, which is a deeper level, the true skin, and this contains collagen, elastin, the reticulum, and a gel-like ground substance. Now, also included in this area are hair follicles, sebaceous glands, sweat glands, blood vessels, lymphatic vessels, and nerves. Within the dermis is the fibroblasts, which secrete collagen, mast cells, which release histamine, and macrophages, which are phagocytic immune cells, and the histiocytes, they're loose connective tissues, and the phagocytize the pigments and the debris of inflammation. So they're kind of the cleanup crew, rather. Subcutaneous layer, or the hypodermis, is that deeper layer yet, and it has fat cells, or the hepatocytes, and connective tissue. There's dermal collagen is continuous within the subcutaneous collagen, and macrophages, fibroblasts, fat cells, nerves, fine muscles, blood vessels, lymphatics, and hair follicle roots. The dermal appendages, nails, and hair. We also have sebaceous glands, which secrete the sweat and the sebum. And then we have two types of sweat glands. We have the eccrine glands, which are used for thermoregulation, and they cool the body through evaporation. And how I remember that is the eccrine sweat glands and evaporation, so E and E. And then we have the apocrine sweat glands, which has very limited proven functionality. Blood supply and nerve innervation. Capillaries provide a rich supply of blood. The sympathetic nervous system regulates the vasoconstriction and the vasodilation through alpha adrenergic receptors, and this is regulated by the arteriovenous anastomoses. Now, I really like this particular slide because it gives us a good visualization of what's going on. And I realize this takes us back to basic anatomy, but if we follow along, we have the epidermis, the dermal layer, and then the subcutaneous layer. Right here we have the erector pili muscle, which helps with the pilar erector function and the goosebump, so to speak. We have the fat. We have our hair shaft, the sweat glands, and they run right up next to that hair follicle. We have our sebaceous gland, which then secretes up through that shaft. The blue cells here are the melanocytes or the melon, and then the Mesner corpuscle is here, and then we have dermal papilla, and then REAP pegs. So when we talk about the aging population and skin integrity, keep in mind that the skin system reflects changes from both genetic and environmental factors. Think of the folks who were sun gods worshiping out, in their 20s and 30s, and now they have that leathery skin in their 60s and 70s. Sun tan or sun protection and sunscreen has not been that pronounced or that promoted for that long. It's only probably been in the last 20 or 30 years that we've really started paying attention to our skin. And what happens as we age is that the skin becomes thinner, drier, wrinkled, and it demonstrates changes in the pigmentation. The number of the capillary loops shorten and decrease, and the melanocytes and Langerhans cells are fewer, and the sebaceous, eccrine, and apocrine glands also atrophy. So then what this leads to is temperature regulation is compromised, pressure and touch receptors and free nerve endings decrease in the number and can reduce sensory perception. So particularly think of those with, the individuals as we age being able to discern hot and cold as readily. Many of the protective functions of the skin decrease, and the chances for infection increases and wound healing is delayed. Now that we've got this basic understanding, we're going to transition to talk about the clinical manifestations of skin dysfunctions. And lesions are typically classified as wet and dry, and primary or secondary. And let's look at primary lesions. So macules are flat and circumscribed, so they're going to be that circular area that is a change in the color of the skin. And they measure less than 1 centimeter in diameter. A papule is elevated, firm, and circumscribed area, measuring less than 1 centimeter in diameter. A patch is more like a macule. It's flat, typically non-palpable, an irregular shaped macule. But it measures more than 1 centimeter in diameter. And the plaque is elevated, firm, and rough lesion with a flat top surface greater than 1 centimeter in diameter. A wheal is an elevated, irregular shaped area of cutaneous edema and is solid and transient. Diameter will be varied. I often think of a wheal as like the tuberculin skin test you get. Nodule, elevated, firm, circumscribed lesion, is deeper in the dermis than a papule and measures 1 to 2 centimeters in diameter. A tumor, elevated solid lesion, may be clearly demarcated and is deeper in the dermis, measures greater than 2 centimeters in diameter. And the vesicle is elevated, circumscribed, and superficial lesion, does not extend into the dermis, is filled with serous fluid and measures less than 1 centimeter in diameter. Now the vesicle and the pustule are different because a pustule is going to be elevated superficial lesion, and while it is similar to that of a vesicle, instead of it being clear fluid or serous fluid, it is purulent. And a bulla is a vesicle that measures greater than 1 centimeter in diameter. A cyst is an elevated, circumscribed, and encapsulated lesion. It's in the dermis or subcutaneous layer and filled with liquid or semi-solid material. And then telangiectasia is irregular red lines and are produced by capillary dilation. So the capillaries become overdilated, and then we get this irregular red line presentation. Now, when we talk about secondary lesions, a scale, I think of fish scales when I think of a scale. They're heaped up, they're keratinized cells, they have the flaky skin in irregular shape, can be thick or thin, dry or oily, and vary in size. We also have lentification, which is rough, thickened epidermis, secondary to persistent rubbing, itching, or skin irritation. And then we also have keloids, which are irregular shaped, elevated, progressively enlarging scar, grows beyond the boundaries of the wound, is caused by excessive collagen formation during healing. We'll see some pictures of keloids in a couple of slides. Also, secondary lesion, a scar. So if you think a scar is a result of an injury or laceration to the dermal layer, and it's going to either be thin or thick fibrous tissue which replaces that normal skin. Escoration, think of the person who continues to itch. A loss of that epidermis, and it's a linear hollowed out and crested area. Fissures, these are linear cracks or breaks into the epidermis into the dermis, and they can either be moist or dry. And then we have erosions, which are a loss of a part of the epidermis. The area is depressed, moist, and glistening, and follows a rupture of a vesicle or a bulla. So think erosion after the effect follows that rupture. Ulceration, loss of epidermis and dermis, is concave, so it digs deep down and varies in size. And then atrophy is simply that the thinning of the skin surface and a loss of skin markings occurs. Now, this is just a review, but let's talk about pressure ulcers. And it's the result of any unrelieved pressure on the skin causing underlying tissue damage, typically caused by shearing forces, friction, moisture, and anytime that the capillary blood flow is occluded, which results in ischemia and necrosis. Now we have decubitus ulcers, which results when an individual lies or sits in one position for a long period of time. Pressure ulcers are graded on a continuum of 1 to unstageable, which comes after stage 4. 1 is a non-blanchable erythema of the intact skin. So if you were to see just that redness or that pressure, redness area, but it's not blanchable and it doesn't penetrate, there's no skin loss. Stage 2 is a partial thickness skin loss involving the epidermis or the dermal layer, so that first or second layer. A stage 3 is a full thickness skin loss. It involves damage or loss of the subcutaneous or the hypodermal area. And stage 4 is a full thickness skin loss with damage to muscle, bone, or surrounding and supporting structures. This is another slide I like because it really highlights the different stages from 1 to 2, and then the bottom 3 and 4. And so you have the skin, and then you have the fat layer, muscle, tendon, and then bone. And then each layer gets progressively further. Pressure ulcers, suspected deep tissue injury, localized in an area of purple or maroon. So if anytime you see purple or maroon discolored intact skin, or a blood-filled blister caused by underlying soft tissue damage from pressure and or shearing. Now, sometimes we'll just say that a pressure ulcer is unstageable, and that's when we have a full thickness tissue loss with the base of the ulcer covered by slough or eschar or both in the wound bed. Think of the areas of bony prominence, so your sacrum, your heels, your ischium, your greater trochanters. Those are going to be your most common sites. And the best way we can use to predict ulcer is that of using the Braden scale. And treatments, so skin assessment, also repositioning and turning, get people off of those bony prominences, use of pressure reduction surfaces and specialty beds, elimination of incontinence, moisture, and drainage. maintenance of fluid, protein, and caloric intakes. And so think of your patient who has um, burns, or they have chronic poor healing wounds, or they have frostbite. We often will say they need that protein source. They have difficulties regulating their thermal regulation as well as their body fluid regulation, so they become dehydrated quickly. They typically have hypoalbuminemia, and oftentimes their caloric intakes are poor. When we want to treat superficial ulcers, if you cover with a flat, moisture retaining dressings that cannot wrinkle, use of specialty wound care products such as dressings, foams, gels, and cleanser. Negative pressure wound healing, so wound vacs, particularly for stages 3 and 4. And, as we talked about earlier, one of the mechanisms or functions of the integumentary system is to prevent against microorganism invasion. And so those who have these ulcers are more inclined to having infection. So aggressive wound control with surgical debridement, proper wound care, antibiotic management, and pain control. Excuse me. We briefly talked about keloids earlier. These are elevated, round, and firm. They typically have claw-like margins that extend beyond the original site. Hypertrophic scars, they are the elevated erythematous fibrous lesions that do not expand beyond the injury border. Excessive collagen formation and abnormal fibroblast activity, typically seen in darkly pigmented skin as well as burns. And we treat it with intralesional corticosteroids, so actually injecting steroids into those areas, cryotherapy, radiotherapy, surgical and laser procedures. Now, a word of caution, if keloids are formed, say, from a surgical scar, yes, you can go in oftentimes and cut out that scar and that keloid, but you always run the risk of having further keloid formation. So it's one of those things, as a provider, we need to keep in the back of our mind. Now, this slide here shows a picture of actual keloid, and you can see where it has that claw-like outreach of the scar. It is hypertrophic, and it has, the irregular pigmentation. The other clinical manifestation of a skin disorder we're going to talk about right now is pruritus, or which is itching. Most common symptom of primary skin disorders. It's seen both in the acute and the outpatient setting. Acute, think of like mosquito bites, surgical wounds, that type of things, versus chronic. So, end-stage chronic disease, kidney disease. A lot of chronic illnesses can have a component of itching. Localized or generalized or migratory, so they're well clustered in one area, diffusely spread out, or they actually follow a migratory pattern. What's causing the itch? There's a specific unmyelinated C nerve fiber that's being irritated. Oftentimes scratching, provides at least some psychological relief, if not actual relief. But the problem is you can get skin trauma, infection, and scarring from it. Now, how do you mitigate that and treat that? You can modulate the central nervous system, and if you can block that C nerve fiber either through topical medications or systemic medications, you can help to regulate that itch response. Now, there is a concept known as neuropathic itch, and that's related to any pathological condition along the afferent pathway. Psychogenic itching is often tied to psychological disorders, and we treat both with topical and systemic therapies. So topical, typically being lotions and powders and creams, whereas systemic therapies, antihistamines, are really good at kind of helping mitigate that C nerve fiber innervation. And right now we're going to stop this portion of the podcast. We'll come up with and start the second part, at which time we'll talk about dermatitis and eczema, and we'll go from there.